discussion. So we are recording this section as we did the decrim section of the day. Just another reminder that only the people who are our panelists will be displayed on the recording. So just feel free to click got it on the pop-up and submit questions via the chat. So I'll just move into the description of the Safe Supply panel. All right, so the safe supply of uncontaminated, predictable, and regulated substances has been a staple in the world of progressive drug policy reform for a very long time. In fact, the notion of simply supplying those who need it with medical grade substances in order to not just prevent death, but to encourage health and well-being has been with us for as long as we have been criminalizing their use. This being true, safe supply is one of the least understood aspects of a health and human rights approach to drug use on the part of many, as the term is often misused and misapplied. Further, how safe supply is reported in the press might lead some to think that a free, safe, and predictable supply of substances is already readily available to any and all who need it, while those most at risk of fatal overdose know this to be false. From bad policy to predictable funding, a truly accessible safe supply for the prevention of death is a long way off. This panel will explore how safe supply has emerged in BC from the risk mitigation guidelines during COVID to seeking a non-medicalized version of safe supply that upholds the rights and dignity of all. And we are joined by our panelists today, Phoenix Beck-McGreevy, Corey Ranger, and Nicole Luongo.
One quick note, Corey, I'm so sorry to interrupt you, but Corey can't make it today, but Mark Wilson is here in his stead, and there'll be he's in this slide deck.
All right, thanks for the reminder, Shane. Okay, so our first panelist today is Phoenix Beck-McGreevy, a queer agender settler gratefully inhabiting the unceded territory of the Coast Salish people since birth. Having spent more than 2/3 of her life as an active drug user, Phoenix is dedicated to improving the lives of drug users and all marginalized and oppressed communities through research, mutual aid, and direct action. I'll just read this one as well. Mark Wilson has worked with Solid, Victoria's Drug Users Union, as a community organizer and administrator for the past 10 years. And our last panelist, Nicole Luongo has spent a decade working in solidarity with those most impacted by the intersections of drug prohibition, housing deprivation, and disability injustice, including as a member of Vancouver Area Network of Drug Users, or VANDU. Nicole is the author of The Becoming a Memoir, published in 2021, and her academic background is in medical sociology, primarily conducting research in the fields of mad and critical drug studies. She currently works at the Canadian Drug Policy Coalition as a systems change coordinator. So yeah, we'll just have the dialogue now. So can we get a spotlight on the panelists, please?
Good afternoon, folks. Thanks for having us. I just want to thank the other panelists and the BCHC for putting on this really important dialogue event. Thank you. I'm sorry to ask this now, but is this like a dialogue? Are we talking to each other? Or are we making our statements? Okay, cool. Okay, so I work full-time as a research associate studying safer supply in a variety of forms. And what I've seen is that the medical model that's been typified by the risk mitigation guidance prescribing that came out over the pandemic is really, it's a step in the right direction for some folks, but it's a half measure. Ever since the introduction of fentanyl into the illicit drug supply, there's been a massive increase in people's tolerances, and providing them with things like Dilaudid is just, it's not workable. And that's not even taking into consideration the barriers that are faced by people trying to access a medical model, people who have been turned away and treated badly by healthcare workers and healthcare providers through most of their lives, just, you know, from stigma and shaming of poverty and drug use. And I mean, really needs to happen is a community-led and community-driven, sorry, my cat's in the way, a community-driven approach to safer supply that actually offers people the drugs that they use in an uncontaminated, in a manner that they know what's in it, they know how strong it is. And until we get there, I mean, all that the medical models have done is increase the amount of prescription meds on the street. And unfortunately, that's just not really workable. I would like to know if there's any questions from the audience, if there's anything that you would like to ask about safer supply, anything that would help you to understand the issue better. All right, so DOLF right now is working on a safer supply program that is really innovative and really seeking to support people's needs. Unfortunately, just due to criminalization issues and issues of stigma and issues of safety, they can't provide people with fentanyl, but they are offering tested and regulated and known consistency batches of crystal meth and heroin and cocaine for people in a limited trial. Unfortunately, the way that they have to do this is by a research study, because what we know as a community is not taken as evidence until it's transmuted through some sort of research process guided by academics. And I mean, while I love engaging that process and while it's critical to do, I think that the main thing that we need to do is to listen to the people who are involved in this. And this is a workplace issue for a number of reasons. I was hired as a drug checking technician at Vancouver Coastal Health, and as a person who they knew was a former, and other coworkers of mine were current substance users, and I experienced a relapse during that position. And when I was approached to treat the issue or to deal with the issue, I was told that the medications that I was on, which is approved OAT and RMG prescriptions of morphine and hydromorphine, were inappropriate for a safety sensitive position. I would have to change my meds that are working for me in order to go back to that position. And I mean, people are being faced with issues like this in workplaces across healthcare and service provision. And it just really, it makes people unable to engage with service provision and unable to engage in work if they're not being allowed to take the meds that they need. And that's not even taking into consideration that people may need to use illicit substances as well. And I just don't understand why things that our doctors are prescribing us are being considered impaired, and we're not being trusted to make the judgments ourselves as to what we can be, what we can take to feel normal and feel healthy to do our jobs. Thanks. I really, what I really want to know though is what is on your minds? What is something that you would like to ask or to know that would make you more interested in safer supply, which would help you understand the issue better? Yes.
Yeah, Phoenix, that's a great time to just remind people to use the chat.
I see one person has their hand up.
Is it okay if I just speak? The question, thinking about this, I'm thinking about also just that kind of healthy critique of the medical model, you know, in the way that it can also really rob folks of autonomy. I just, are there examples of models or processes that would be better and yeah, that would actually be better, that would allow folks to be able to identify their needs? I think actually personally also just like medication and drugs wise, I take Adderall. Mm-hmm. And to be able to take Adderall, they, like my pharmacist and my doctor, allowed me to try out different dosages until I found the window that worked for me. And I was able to speak to that. And there was just a lot of evidence that made it, of course, that makes sense. Like, how would somebody else arbitrarily tell me what my dosage should be of, a pretty like impactful medication or drug? So how is it possible? We work at the Health Coalition. We know this to be true in so many ways of how the medical system works, of denying and sometimes undermining folks' autonomy. How is there practices that you have heard of, or good policy around this, or good practices around this that actually affirm people's ability to identify?
Well, I think in any position, you really want to have policies that are based on behavioral and fitness for duty, not what people are taking or not taking or anything like that. And I mean, it has to be really clear, because obviously if somebody shows up and they're not fit for duty, they need to be able to be told that in a way that they can clearly realize, okay, this is a problem. But I mean, I'm sort of the opinion that all of us use drugs in some way or another, and it's just the bodily autonomy of being adults in a supposedly free society and not being able to choose what we put into our bodies. I mean, I honestly just think that a safer supply program like the liquor store would just, that's the sort of thing that we need. Just like go to a store, buy what you need, and like the misperception that people have of safer supply and what's available is that it seems counterproductive to just give drug users drugs, but it really isn't, because it's not the actual drugs themselves that cause so much of the problems and so much of the harmful conditions and all of the behavioral issues. It's the framework around it of criminalization and stigma, and capitalism really plays into it quite a bit. It's the need for money to buy drugs that are criminalized that puts people into situations where they make bad choices. So if that was removed, I really think that a lot of what we're seeing as negative would clear up. I don't know if that answers your question, and I'm sorry if it doesn't, but I feel like approaching it from a behavioral issue of saying, like, this is your role, this is what you need to do, this is what you need to be able to do this role, and here's what will happen if you don't, rather than just approaching it from, what people are on or not on.
Thanks so much for that perspective, Phoenix.
Thank you.
Yeah, I think we'll move to Mark, and then we'll hear from Nicole after.
Hey folks, just wanted to introduce myself because I'm coming in a bit late to the conversation, but I'm a non-experiential employee at Solid. I've been working at Solid for about 10 years. I was brought on as a community organizer to start with, and then to help out with policy, lobbying, and all that stuff over the last decade. And I think Phoenix said it really well around where the need is. Like, I think it's really clear there's a need for non-prescription, non-medical safe supply. And that one of the biggest barriers that the communities aren't trusted to know what they need and to be able to guide in providing those services. And just looking back, the thing that scares me is the risk of making the same mistakes we made over the last decade in overdose prevention services. So, we knew after Insight started that injection services were needed. Here in Victoria, we fought for them for about a decade before they came in. And then by the time they were available, you're offering injection services in a big clunky format right when folks are switching to inhalation. And so you see this long process with the way that, are folks having a hard time hearing me? I'm just gonna hold this like this. The big risk I see in any giant government intervention when they don't trust the communities to take the lead is that you end up doing what we already saw with overdose prevention so far. One of them is incrementalism, which is you just take these small steps trying to do the minimal amount possible. And I think we've seen that across the board from injection services through the decriminalization. I think we see a lot of proceduralism, which is for years we heard all this red tape, like here's the reasons why we can't do an injection service. Here's what you have to do to get there. And it took 10 years on how people died in the process. One of the most interesting things from the policy side to watch was when that ministerial order came out in 2016, and it made it clear that a lot of those procedures didn't really matter. It still took 2 years after that for Victoria to get its first injection site, but it was still on the old exemption model, when at the time we knew, based on the ministerial order, all you need now is the funds to have 2 staff in a room, and you can serve a few hundred people daily. So it was weird to see the shift from this is a nearly impossible service just to have a room where folks can inject, here's all the difficulties and all the reasons you can't do it. And then with a strike of a pen, in some ways, it all of a sudden becomes very easy. And there's services like that all over the place now. We run 6 of them in Victoria. And I wonder how much of that we're seeing now with Safe Supply. We're just seeing all these reasons why this can't be done. Here's the things we're concerned about. Here's the slow piece to it. When I see the same capacity under the ministerial order to say, hey, let's move, let's go. It's an emergency, we don't have time. So I think these are some warning flags to look at in the way we've seen things roll in the past and what I see in the same conversations now. And I think the third is that bureaucratization, which is this strong sense among government and government services that you can't trust communities to run their own services. The ball has to be held. And I think we saw that with the big clunky injection sites, which they're run by large organizations. The health authorities heavily involved, and they end up being a large service that can't change fast enough. And we know that drug user groups on the ground providing services that know what's needed and can do a very responsive version of what's needed and can change really quickly to meet needs as they come up. So I think the lesson is, to listen to the groups on the ground and to know that most of these things are much easier to do than it appears. The biggest problem I see when we're talking to government right now about the prescription model is that they're working on this. It almost looks like a 5-year plan around training physicians and making sure all these things are available. And a 5-year plan isn't appropriate in an emergency. We keep having to say in emergency settings, you need to provide something right now. Too many people are lost in the meantime while we're waiting to create the service. And it also ends up being ineffective. You create a big clunky model, then 5 years isn't going to be where people are at. So I think, what Phoenix is saying is if someone says they need something right now, you're giving them that product. You're not giving them some other thing because it's easier to reach. If Dilaudid is more accessible right now, that's not going to be necessarily working for people. And whatever system we're building right now is very likely not going to be up to the task of where we're at in 5 years. So we need a more responsive, very quick model. And I think that's what we want to see in an emergency. In some ways, we saw it. I saw it with COVID. I saw what the government can do in 2020. We'd all been in an emergency, seen friends die for years with not much. We saw this incremental proceduralist kind of model of like, hey, we'll try this. We'll do a bit of Narcan in 2016. We'll try to provide some injection services in 2018. 2020, we saw 2 things happen. I mean, it was mainly the funding. All of a sudden, they were throwing money at us saying, hey, start up this service. And that right then allowed us to start 4 or 5 overdose prevention sites. So we couldn't start just because the money wasn't there. So I think if we're seeing anything, it's remove the barriers and then fund groups on the ground to do the service they know how to do and trust them to do it. And I think there's an already existing model to do that through the ministerial order and through the medical health officers who have direct communications with community organizations. And so what we keep saying is use the ministerial order to remove the barriers. Let's stop talking about prescriptions. Let's stop talking to all these physicians and stuff that are never going to meet the need. There's a bottleneck there that's never going to meet the need, and get a list of doctors who say they can't do it. And secondly, trust health officers to have that relationship with community organizations, like they've done with Dolphin, like they've done with Solid, to start up a program and to review it and then to extend it. And it's a model we have right now to do a service. And it involves something that I think we've seen government is very bad at, which is trusting organizations, allocating funds, and removing barriers. And I think that's what we have to demand. And I think looking at the failures of the past decade can help us get there. I just hate to see the same thing happen again. And I know it's going to. Like, I just from what we see, we know we're going to be talking for years about what prescription safe supply looks like. And it's going to be on community organizations to provide that safe supply in the meantime. But it's difficult and it's never going to be enough without that partnership with government. So those are some demands that I think are useful to keep in mind. And I think it's very easy to point to how not doing that is a major issue. We don't want to be incremental. We don't want to be caught up in regulatory frameworks that we know we can just throw away in a second with a piece of paper. And we don't want to get caught up with big, clunky government projects when we know community organizations can do it better. Thanks.
Yeah, thanks, Mark, for showing us like what's possible, how much movement we can really make in a short amount of time, because it's been done before. Yeah, so now we have Nicole to just say her her piece on the panel.
Hi, everyone. Thank you for having me. Sorry, I'm just trying to orient myself here. Yeah, I know this is a panel about safe supply. My work with the Canadian Drug Policy Coalition focuses really more specifically on full legal regulation as kind of a longer term, although hopefully a more medium term objective. And yeah, to kind of orient you to me and how I arrive at this work. You know, I have a long history of what gets labeled as addiction, and with that, you know, homelessness and involuntary psychiatric institutionalization and kind of all the trauma that comes with that. And you know, through that trajectory over many years, you know, I spent a lot of time in abstinence-based addiction treatment centers and 12-step programs and other like hyper medicalized contexts, and eventually kind of, you know, have not come out the other side, because that implies more of a linear narrative than really exists. But after being dissatisfied with those models, I kind of gravitated towards like medical sociology and kind of modes of knowledge that allowed me to critically interrogate why for so many years I was told over and over by, you know, professional authorities that kind of the locus of the problem resided in me, and why none of the kind of care, if you'll call it that, I received offered me any sort of insight into like the political aspect of who gets labeled with addiction, why we get labeled with addiction. And over time, I've begun to see that, you know, illegal drug use is a lot of things to a lot of people, but those the people who are going to probably be criminalized or labeled with a disease are those who are hyper visible. So, you know, visibly homeless populations, racialized groups, indigenous peoples. And I've started to think about that as more of a way to control and regulate kind of unwieldy or deviant populations. And so looking at safe supply through that lens, you know, Phoenix and Mark have both touched on just the extent to which it's inadequate, because in order to access it, you have to be labeled often, not always, but most of the time, with, you know, a treatment-resistant substance use disorder. And that just opens people up to a host of other forms of kind of coercion and surveillance. And so when we think about moving forward with drug policy, you know, safe supply is kind of, I hope, a layover at the moment. But the reasons I advocate for legal regulation are not just to stop overdose deaths, but it's really to improve quality of life for everyone, but particularly people that are highly stigmatized drug users. And I'm, you know, fairly, I reiterate often that like the principle of informed consent and that of bodily autonomy, like we can't really adhere to that when people aren't given the choice whether or not they are labeled with addiction or aren't given access to alternate forms of knowledge about themselves even. And I think that's like a really insidious and protracted form of violence that isn't talked about enough, in the sense that we hear much, and rightfully so, about, you know, incarceration statistics, overdose death statistics, violence that occurs with police encounters. But at the end of the day, like if you are telling someone you're sick, you have a broken brain, you're diseased, you can't trust your thinking, I know from experience and from research now, the extent to which that really undermines our ability to live full, rich, meaningful lives, because we're trained to be terrified of ourselves. So that was a long rambling something, but yeah, the point I'm trying to return to is that when we talk about drug policy, it's not just about kind of those really like mitigating those immediate and very obvious negative consequences of drug prohibition, although that is of course a short-term goal. It's about living in a world where people have the capacity to choose for ourselves who we are, what our behaviors mean to us, and not face various forms of social exclusion and stigma because we choose to alter our consciousness. I think that to me, that's kind of a human right and not something the state should be, not that I'm like a libertarian, but not something the state should be trying to prevent us from doing in the course of ways it does. Yeah, I guess I could go on to talk about what legal regulation is more specifically, but maybe I'll pause there for a moment to see if there are questions or things I should follow up on.
If I could just jump in about regulation versus and decriminalization versus safe supply. The problem with looking at decrim and that sort of thing as an avenue to take to deal with this is that it doesn't address the toxicity of the illicit street supply. So we can decriminalize certain amounts based on what the cops think we should be able to carry, but it still doesn't change the need for a safer supply in terms of changing the actual substances available to people on the street. And so I think that's just a really important perspective to take when thinking about decrim and legalization.
Yeah, definitely. And I can elaborate on that a little bit. So when I say legal regulation, some people assume it's synonymous with decriminalization. It's not. Decrim is, of course, removing criminal penalties for simple drug possession and ideally all forms of necessity trafficking and beyond. And legal regulation consists of that. That's kind of the legalization part, but the regulation part is about introducing pharmaceutical grade drugs back into the economy through legal avenues. Or I guess, yeah, and in so doing, because legal regulation is not, people often have a knee-jerk kind of aversion to it because they assume it means that drugs are going to be kind of manufactured and distributed through corporations, much the same way alcohol is, and that doesn't have to be the case. So in my work, I work with a group of people, won't get into the details, but basically look at kind of different models of legal regulation. So on one end of kind of the spectrum of restrictiveness, we have things like safe supply, where again, you need to kind of adhere to like biomedical framings of drug use, and it's very high barrier and often doesn't meet consumer demand. On the other end of the spectrum, you have alcohol and to an extent cannabis, which are legal psychoactive substances, but which are kind of regulated through a capitalist framework. So when we talk about legal regulation, it's about looking at how do we introduce drugs that people can procure without necessarily encouraging drug use and putting in reasonable protections to prevent, certain populations from having access to drugs when maybe they don't want to have as much access, i.e. young people, putting in protections for things like corporate advertising. And so, in Vancouver, where I'm based, we have groups like the Drug User Liberation Front and the Vancouver Area Network of Drug Users. I know there are analogous programs happening on the island as well. I won't say too much about that, but where people who use drugs are purchasing drugs and testing them, packaging them, distributing them through a compassion club model. And that, again, there's lots of variability there, but the core tenets are not for profit, meeting people kind of where they're at in terms of their desired forms of consumption, routes of consumption with the amount of drugs they want, but there are like quality and safety mechanisms in place. So I just want to clarify that when it comes to legal regulation. It's not just removing criminal penalties, it's doing that plus introducing legal channels through which to acquire drugs that nonetheless are ideally rooted in the tenets of social justice and participatory democracy and righting some of those historic inequities that emerge as a result of drug prohibition.
Yeah, thank you for making the distinction between those two terms. I think they do tend to get confused a lot, so that really helps. I don't know if Mark, if you had anything to add to that point about decrim or legalization, or I just wanted to give you a chance to add something if you had anything.
Yeah, I mean, I think on that conversation, it shows where the government can step in to provide something useful, which is decriminalization takes away the criminal effect that makes the whole market as messy as it is for folks. Like whenever a dealer gets picked off in Victoria, it sets the market in a messy situation where someone doesn't know where to pick up, they're using less safely. So at this point, criminalization makes people unsafe. What we're saying right now to the province is groups are forced to take care of themselves and purchase black market product that is as good as it can be, but it's uncertain and unreliable, and you can get it tested as much as you want, but where the next piece is coming from is difficult. The government can make
Sorry to interject. Do you mind just holding your mic closer to your
Oh yeah, sorry about that. Yeah, something the province could do right now is provide pharmaceutical grade heroin so that it's available for folks to distribute rather than rely on illicit substances. Having that reliability is a big piece of people able to use heroin, because since you're going through withdrawal, there's a great danger in having your supply disappear and having to go back to fentanyl. So the reliability piece is massive, and the black market can't meet that need. So though, to me, it doesn't seem to me there's any reason why the province couldn't directly purchase from Pharmascience or Fair Pharma a large amount of diacetylmorphine and make it available. They don't even have to know yet how it would get out. They just need to start the process. And I think one thing bureaucrats love to do is talk about worst case scenarios, and often part of this whole process of proceduralism is like, what can go wrong? And the weirdest thing in this case is the worst case. We're already in the worst case scenario where we're stuck with very, very volatile, constantly changing street supply. We had 2 staff die just 3 weeks ago when xylazine was in fentanyl all of a sudden. So small changes can take out someone with a very high tolerance. If the government was to purchase a large amount of diacetylmorphine, and even if worst case scenario, that supply were to get everywhere, that would be much better than the current situation we're in. We know that wouldn't happen anyways, because we've got groups that have already shown they're capable of handling product and making sure it gets to the right folks in a pretty easy way, in a very streamlined way. So it's a case of, I think this is very similar, and I think we should compare it directly to what we saw with injection services. We spent 20 years fighting for them, and in the end, it's just some people walking into a room and getting some medical services. It's not complicated, and I think it's the same with safe supply. So I think thinking about that way and disregarding all the rules that we think are there, but that we know could be overcome in a pretty straightforward way, would allow a lot of people's lives to be saved pretty quick.
Fortunately, the issue with that is that with people's current dependency on fentanyl, their levels are too high for the heroin to actually do anything. If heroin had been introduced widely like 7 years ago, it might have been a thing, but unfortunately, like, fentanyl just took over. And to answer the question that was in the chat, a big part of it is that fentanyl is much more potent, so it's much easier to ship and sell. But unfortunately, that also means that the amounts that people are buying on the street, because people buy drugs by weight. And so if the potency of the substance that you are buying is much higher, you don't need as much of it. So that means that the drugs on the street are up to 95% filler or worse, which is really, really dangerous and really toxic. So unfortunately, the fentanyl problem is here, and it's something that we have to deal with.
And I think that's a great conversation, and this comes down. Oh, sorry. Go ahead.
Oh, sorry. Yeah, just keep on going. And for everyone, anyone who has questions, feel free to put them in the chat.
A quick comment on that, because I think that's the great piece around user-run programming, is realizing really quickly what's needed and the variety of options that are needed for folks. And I think when I'm talking to other clinicians, they're saying this would take years to figure out in a clinical context, because it takes so long, and there isn't the ability to offer the variety to folks. And so this is where I think the strength of Heroin Compassion Clubs lies. And like you're saying, it doesn't have to be just heroin, because folks are going to be either starting used to fentanyl and wanting to stick with it. In some ways, we've run a similar program that's doing fentanyl without benzos, which in itself is a big step for folks. and then offered a program for folks with heroin who want to scale back. And that's folks who are previous heroin users who are going to go through a certain amount of withdrawal. And we're already finding staff who can sleep through the night, like folks who, because heroin's got more legs and lasts longer, you're not going to get as much of a high, but you're going to be able to get through your day and manage a lot better. So I think there's a lot of on the ground knowledge folks can bring to any kind of setting around this stuff. And there's a lot more room when we're not dealing with prescription models for folks to get what they need and to create management schedules that work for them. And I think, kind of like Nicole, actually I think like you've both been saying, the less we criminalize folks and try to coerce them into doing certain things, by forcing these models, the more room there is for folks to take control of their lives and help each other out. So I don't think we're far from it. It really is the sense of regulation and the sense that there's a mistrust where you need doctors to control patients and you need government to control communities that I think is a big piece of the struggle here.
Yeah, any last thoughts on the prescription model and pros and cons of that before we move on to the next question? So our next question is, what sort of organizations are best situated to offer safe supply? Is it harm reduction organizations, pharmacies, who?
I mean, I take seriously the tenet, nothing about us without us. And when it comes to drug user groups, of which there are many, I think, people who use drugs are best suited to know what is happening with both the drug policy environment as well as just interpersonally. So I think the key, and I'm not sure what was said this morning, but one of the missing pieces there is resourcing drug user groups. Within BC, there are massive resource flows being distributed, but they often tend to be reabsorbed back into health authorities, levels of government, and more of these kind of institutionally legitimized spaces. And drug user groups who are doing the life-saving work and who have such a wealth of insight are really left fighting over scraps. And part of me, not to get conspiratorial, but I believe to an extent, at least implicitly, there is kind of the government is incentivized to sow divisions, right? And to divide groups. And when there are very few economic routes to sustain oneself, that is what happens. So I think drug user groups are the kind of best equipped to design and implement Compassion Club or peer-led programs, but they also need to be sufficiently resourced to do that. Yeah, definitely.
You can't have one without the other.
Yeah, and also just note, I don't want to present drug users as a homogenous group, because we're very much not. And I know, like with the CDPC's Imagine Safe Supply research stream, and the work I've done talking to people and everyone on this call who's in those spaces, we know that there's a diversity of perspectives and opinions and desires. And so I don't think it's wise or useful to make blanket statements, even though I just made a bunch of blanket statements. But in some contexts, there are going to be people who use drugs who actually say, no, I want access to health and social services. I need to have medical care. So these things are also very context specific. And that's where really robust consultation comes in and stuff. But at the end of the day, again, those resource flows are really instrumental as well.
And you can picture how easy it would be for any current overdose prevention site to have a dispensing model for folks. And it's wild that doesn't exist. There's been a few failed attempts with IoT programs, but again, the focus on prescription is the bottleneck. Prescribers can't reach enough folks. There's no way a doctor can be expected to do that many prescriptions. And the surveillance model doesn't work for a lot of folks, including Carrie's and for a lot of reasons like that. So if we think outside the box of coercion, control, and prescription, you can picture using existing frameworks where services already exist to give folks what they need where they are.
Yeah, and I just want to highlight the comment in the chat from Jerica, who says, also having these supplies in accessible areas. So yeah, meeting people, geographically where they're at too. So our next question, maybe we'll run that question from Shane into the question from Mazdak. Sorry, not from Shane. So are there current examples of effective safe supply programs in BC? And then Maz says, when politicians in BC say we have safe supply and people can access it, what are they actually talking about, given that that's not the case?
They're primarily referring to the prescription programs, such as the risk mitigation guideline prescribing that came out that was tied to the pandemic, and further attempts to scale up that model, giving people access to certain stimulant prescriptions like Ritalin and Dexedrine, and expanding short-acting opioid access. But to me, this is really just opioid agonist therapy with a little bit of crumbs thrown to stimulant users. It's not a true safer supply because it's not in a format that works for people. It's not the substance that works for people. And what I've learned in all of my years of research on safer supply is that there is no one size fits all model. There needs to be models that are tailored to different approaches, to different communities, to even different geographical regions. And some people, like was said, are going to want a wraparound care sort of environment where they can access healthcare and other sorts of social services while they're receiving their prescription. Some people just want to get their shit and go. And so until we are able to really implement that robust consultation and really make approaches that work for the people that are going to be using them, it's going to be this half step of RMG and this half step of Dilaudids to fight fentanyl, and offering Ritalin for cocaine users, which most people who use stimulants have probably investigated prescription stimulants before, maybe ADHD diagnoses. Like, this is not new territory for people. It's just retreading the same paths over and over again.
It might also be helpful to just kind of provide an overview of the bureaucratic and legislative framework that's at play here. So of course, in Canada, we have the Federal Controlled Drugs and Substances Act, and that is like the key framework for overarching prohibition. And then when it comes to safe supply, the federal government kind of near the onset of COVID did kind of expand access to prescriber-based models of safe supply. So as far as the federal government's concerned, safe supply is legal. However, health is primarily overseen and implemented by the provinces. So right away, we have this fracturing where some provincial health ministries and territorial health ministries have not even entertained the idea. In BC, we have, but in BC alone, we have 5 regional health authorities who kind of work under the provincial health ministry and are mostly accountable to it. And then we have municipal governments who have very little power. We have the colleges of the regulatory colleges of pharmacists, as well as the regulatory college of physicians and surgeons who direct individual prescribers. And so you have this kind of, like, you can call it almost a supply chain or a chain of command that is so fractured and goes off into so many different nodes that by the time you get from the federal government to a drug user who wants safe supply, there is ample opportunity for that to break down. And that's what we're seeing. So yes, the province of BC technically has routes to safe supply, but those are concentrated in urban regions, Vancouver primarily, and Victoria. And there is no way that someone in a remote and rural area on reserve is going to be able to just walk next door to a doctor and say, give me a prescription for safe supply. It simply isn't working that way. And it's really left to the whims of individual prescribers, many of whom arrive at their jobs with lots of stigma themselves, some of whom just unabashedly hate drug users. And then even the ones who are more progressive are feeling kind of beholden to their regulatory colleges, which are very conservative and won't hesitate to launch investigations. You've got this intermediary with the regional health authorities. So when politicians say safe supply is available, they are technically telling the truth. But what that practically looks like, and that doesn't even touch on the actual drugs that are available for people in the routes of consumption, because usually they're not preferable ones, like Phoenix said. And it's a way for politicians, I think, in BC to really kind of launder their reputation. BC is seen as kind of this liberal or progressive panacea relative to the other provinces and territories. And what we see over and over is that there is, this dialectic of really rich, principled activism, people demanding progress, get these kind of co-opted and sanitized versions of their demands. The government then uses that as fodder to say, look at all the good we're doing, but because the policies that drug users actually want are only partial and they aren't being implemented as desired, they don't really work. And my fear is that we'll see that with this decrim pilot that's forthcoming. We are currently seeing it with Safe Supply, where the state lies and says, look at all the good we're doing. The policies aren't really working as ideally intended. People are continuing to die and quality of life isn't improving. And then that gives ammunition to more conservative regions to say, look at what those, progressives or liberals are doing and it's not working. So actually criminalization and abstinence are probably helpful. So it's this kind of constant pendulum swinging. But what is important, I think, to take away is that what is being said is not what is being done, and the requests and demands of people who use drugs, who know what they need for themselves, have never been met or anything close to it.
That's not even taking into consideration the way that the individual health authorities interpreted those guidelines and interpreted that, like, since it was tied to COVID, people, prescribers in different health regions were saying you had to be suspected of having a COVID infection to access the prescribing. You had to have, all these different strange interpretations of what that actually meant in order to access it. And it is incredibly badly focused on urban areas. Like it's a program that might actually be of assistance to people outside of urban centers, but they're not receiving it. And then it's actually not helpful here. It's just really lopsided.
And one thing was a surprise to me to see after talking to doctors the last few years was that the government can say doctors are allowed to prescribe, but it doesn't mean physicians will do it. And they have a lot of reasons for not doing it, even the most compassionate and supportive physicians. And I think listening to physicians about the reasons why they're not able to do it is the most important thing the government could do at this point. And it's not just physicians who are anti whatever. It's physicians who are saying this isn't our job. Like, you're doing something that's not within the medical system. We're not doing people's health here. You're trying to do something different. It's harm reduction. So it doesn't need to be medicalized. And I think that's some of the most powerful voices I'm hearing from physicians, that I hope, and I keep telling various officials, listen to that. Because almost it doesn't the reasons they don't want to do it almost doesn't matter. Physicians are saying we're not going to do it, and this is a giant bottleneck. And even in urban areas where it's happening, we're serving like 100 people in Victoria. That's a tiny fraction of the folks who need the service. It's never going to work. It's never going to reach enough people. And if they want to build that up, I think that's great, because like folks had said, you need a variety of things for a variety of people, but it's going to be a long term. It's going to be a 5-year program to build that. And it's going to be good for some folks. But in the meantime, we're in an emergency. People are dying every day. What are we doing right now?
Yeah, and I'll just add, I think a really important thing to highlight, particularly with this audience, is that like many people who use drugs don't identify as experiencing addiction, right? They are recreational users or episodic users, and are, don't fit the stereotypical profile of an illegal drug user. So right now, because Safe Supply is so rooted in the notion that you need to be sick, and this is a life-saving measure and a last, kind of last kick of the can for you, you have people that are dying that are employed in the trades, employed with the BCGEU, who are not visible drug users, and are otherwise, living their lives. But because they are then forced to go to the toxic, illegal street-based supply, are experiencing the ramifications of its toxicity. And that's because Safe Supply is so restrictive.
Are there any other questions for the panelists? Shane, I just see your last question there, but I feel like Nicole may have answered it. The question is just, given that a solution is available, what's happening at the government level that is preventing a solution?
Yeah, I'd like to also know, like, so, can I ask, sorry, Adrian, can I ask
Yep.
a question? I should ask it first. Since the beginning of the pandemic, the BC government has put all these different institutions in place. We have the OERC. We know a lot of money is flowing from the provincial budgets. There's the BC Center on substance use. Like, where do these institutions fit in BC in terms of like collaborating, in terms of trying to find a solution to this problem? Like, I live in BC and I find it really complicated. I'm wondering if you have any insights. I see that Trish has their hand up too.
My first thought is it's very difficult for government bureaucracies to provide emergency services. It's not the right mindset for creating an innovative, rapid solution. So if anything, I think there needs to be much more collaboration with folks on the ground directly wanting to do something. And like I was saying, removing barriers and providing funding. Bureaucrats are they're trained to come up with reasons why things can't work and to find circuitous ways to work around them, but we're seeing a passing of the buck at every level of government saying, we don't want to change our rules, so can you just change yours? Or we can't do this, so can you do it? And that's why the buck right now is sitting with the doctors. The government's saying, we don't want to change our rules, so doctors can do this, doctors saying that. So I think the passing the buck has to stop, and the province needs to take responsibility and say, hey, we are going to change these things. We're going to remove these barriers. And until we see the Ministry of Health taking that seriously, I don't think we're going to see any changes. So unfortunately, the wrong person is in charge of the Ministry of Health right now. And until that changes, that's where the sticking point is that I'm seeing.
Yeah, I think really the role of these organizations is to work in partnership and in support of drug user groups and people who use drugs on the ground, helping resource flow, helping with administration, helping with these sorts of things that maybe aren't the strong suits of groups that are doing the work on the ground. Some of them are really strong in these administrative capacities. Lots of different people are drug users and are members of these organizations, but really just as a supportive partner in the work, but not taking the lead.
Trish, I know your hand is up.
Yeah, I was just wondering, I see in the media a big voice in this is the chief coroner, Lisa Lapointe. And I'm wondering if she is working with drug users and drug user groups and what people think about her perspective and the reports that she's putting out. So that's one question. And then just wondering what you're hoping for, or if you have any hope for what's going to come from this consultation that the Select Standing Committee on Health just ran. And I think the report's supposed to come out in November.
I don't know talk too much, but yeah, I think we've seen great activism from some folks in power. Like Lisa Pointe done some amazing work. Bonnie Henry and health officers have been forced to really step in. And it shows a bit, I mean, it's been interesting seeing the politics, just seeing how decisions get made and how they happen. But you can have a range of these individuals with really great approaches, and it doesn't translate into policy change, given the way the Ministry of Health works and where decisions get made. So let's leave it at that.
Yeah, I don't want to speak too much on Lisa Lapointe simply because I'm not too knowledgeable about what her actual process is. Part of me believes she sees the direct outcomes of our drug policies, right? And I can't imagine that is easy, or I think that might kind of desanitize some things for her. I don't know. I will say with regards to the BC Select Standing Committee on Health, it's very easy to be cynical. It's very hard to be optimistic in a lot of different ways. I see it and many similar legislative processes or governmental processes as having some potential, but any group or any group of groups can make all the recommendations in the world. And at the end of the day, it comes down to political will and the desire to adopt them. So I know for the Select Standing Committee, I did, read the terms of reference and some of the transcripts, and it seems as though the people overseeing it, the MLAs, is it MLAs, right? MPs, MLAs, sorry, involved seemed to be arriving with very little subject matter expertise, let's be honest. Some kind of questions were asked throughout, and some processes were followed that were a bit, they were head scratchers, so to speak. I know that a number of abstinent-based addiction treatment centers were invited to speak, as were kind of drug user groups. So I appreciate that there was maybe an attempt to balance perspectives, but as I regularly say, like, the perspective that drug prohibition has been immensely harmful for the entirety of society for hundreds, decades, but longer really, of years. That is rooted in, kind of empirical evidence, if you want to use that word. It's rooted in it's objectively true, using all available metrics. Whereas, and Mazdek, I saw your comment or your question in the chat, and this ties in a bit, the for-profit abstinence-based addiction treatment industry, which was invited to speak to the BC Select Standing Committee, and which does have an economic and ideological stake in maintaining drug prohibition. Their perspectives are not rooted in anything that would even begin to really constitute evidence. So giving equal weight or kind of both sidesing the argument is not an apolitical thing to do, right? It is implicitly political. And so returning to the BC Select Standing Committee, do I have a lot of hope? I'm more concerned that David Eby, who will likely be our next premier, maybe, has been making the rounds in media touting interventionist approaches and what amounts to incarceration for people who overdose, and using really stigmatizing language to do so, and kind of depoliticizing and individualizing this social problem, while kind of regurgitating the party line around safe supply being available. So yeah, I'm more cynical than optimistic, but I try.
Yeah, and I mean, just in terms of the process, like, I understand that they have a methodological approach that they need to take to doing this, but it really doesn't invite and make easy and facilitate the participation of people who use drugs that may not be organized. And I just think that it would be more helpful to try and go out and seek opinions from people, and to try and make the process easier for people who have a number of barriers and challenges in front of them to participate, rather than just, seeking input from people who have the tools and the capacity and the ability to write and stand and travel and do all of these things, instead of, people who may not have access to these types of ways of having input.
And I would just add that all of these things, to me, don't appear to be how you act in an emergency. And it shows me that the government does not think this is an emergency, really, and doesn't take the lives all that seriously that are being lost because of stigma. And until that ends, I don't think more people dying who use drugs is going to see that much of a response from the province. It's going to be treated as we got a 5-year plan, and it's not going to be treated like, right now we need to do something. And I just keep thinking, I mean, you can use all the metaphors you like, but I just keep thinking about water's gushing down the streets and it's flooding, and we're like, what? Let's have a stand, let's talk about it. And I was like, no, you're out there right now putting sandbags in, and that's breaking some laws because you have to do it. Like in an emergency, you do what needs to be done. We're not doing that. I saw us do it in COVID when we knew the threat was to everyone, and I don't know how we can change the language. So the threat here is to everyone. It's to everyone, and all the people we know, everyone's at risk. And this image we have that somehow only some certain bad person is making a bad decision and dying and it's their fault. We need to get over that somehow, because I think that is behind the lack of action here. And I think we need to keep saying this is an emergency. We need emergency responses.
We have time for maybe one more question. Carmel, I saw your hand up. Did you want to say something?
It's not more or less a question. It's just that I read the coroner's report from July 2022 this year, and from 1990 all the way up to now, deaths have not gone down. They've only skyrocketed up. So I agree with you, Mark, that it's such a pivotal emergency situation. And I'm very curious as to what emergency standpoints we can have in this community to move forward with. I just wanted to point that out because I was just not shocked, but like it's in format, yet there's nothing done with our political individuals to know that. Yeah, I just wanted to point that out.
Yeah, thank you. So at this point, we will have a break, but before that, just a huge thank you to Mark, Nicole, and Phoenix for that amazing panel. Yeah, like Craig said in the chat, I've also learned so much, and I'm sure everyone else has as well. So thank you so much for your perspective, and we will break until 2:20.
Thanks, everyone.